Thank you for joining us for today's webinar, Exploring Minimally Invasive Techniques for Pancreatic Cancer. My name is Suzanne LeBlanc, and I am a radiologist and Director of Clinical Relationships at the Focused Ultrasound Foundation. Now, Kim Martini-Fear, the Education, Grants, and Special Projects Director at the Society of Interventional Oncology, could not be here today. However, she stated that the Society of Interventional Oncology is proud to partner with the FUS Foundation to advance education on minimally invasive techniques for pancreatic cancer care. They value the opportunity to collaboratively share emerging approaches and contribute to the innovation of patient-centered treatment strategies. We also planned to have this webinar near November 20th with respect for Pancreatic World Cancer Awareness Day. Now, I'm thrilled to be here with my co-moderator, Dr. Zachary Berman, and an exceptional panel of experts who are each pushing the boundaries of what's possible in the treatment of one of the most challenging cancers we face. Now, pancreatic cancer affects more than 500,000 people around the world every year, and despite major advances in oncology, it remains one of the leading causes of cancer-related deaths. For this reason, innovation in treatment options is not just welcome, it's urgently needed. Now, today we're fortunate to hear from 3 leaders who are each advancing a different minimally invasive technology with the potential to dramatically shift the landscape of pancreatic cancer care. These presentations will explain the use of catheters and blood vessels to increase drug delivery, the use of focused ultrasound machines to treat through the intact skin to kill and ablate tissue, and the use of probes placed through the skin to ablate tissue. Now, while some of these discussions may feel highly detailed, I encourage you to keep the broader perspective in mind that advancements in technology can expand the tools available to physicians, helping them deliver new treatments for patients with cancer. These minimally invasive incisionless techniques have the potential to shift pancreatic cancer treatment from managing a disease with a limited lifespan to treating it more like a chronic disease. Now, before we introduce our panelists, I'd like to take a moment to highlight the expertise that Dr. Zachary Berman brings today. He's an associate professor of clinical radiology at UC San Diego and a nationally recognized leader in interventional oncology. He's authored more than 30 peer-reviewed publications and book chapters and has delivered over 60 invited lectures across an international platform. He's part of a 2024 phase 1 clinical trial with immunotherapies and IRE in locally advanced pancreatic cancer. Now, we're delighted to have him help guide today's conversation. After our presentation, Zach and I will moderate a live Q&A session, which will last until about 4:15 p.m. So please submit your questions using the Q&A function at the bottom of your screen. We will address your questions and also address the real-world challenges and opportunities of bringing these technologies into clinical trials and commercialization. So with that, let's get started. And Dr. Berman, the floor is yours.
Thank you for such a kind introduction, and thank you for everyone for coming. I am also equally as excited to see all of the presentations today, because I think it's been a renaissance of new approaches and new ideas and new variations on old themes to see how we can make the care for these cancer patients even better. So with that, I'd like to get started with Dr. Farsad, who's going to be discussing Trans-Arterial Micro-Perfusion, also called TAMP. Dr. Farsad earned his MD PhD from Yale University, and he's the Joseph Roche Professor and Chair of the Department of Interventional Radiology at Oregon Health and Sciences University. He's also the director at the Daughter Interventional Institute and director of research. Dr. Farsad's areas of clinical and academic interest include image-guided treatment of solid organ malignancies, and Dr. Farsad oversees the research activities in the Department of Interventional Radiology, which includes many clinical trials and translational research projects. And so with that, I'd like to welcome him to discuss these treatments.
Hello, everybody. It's my pleasure to be here today, and I thank the organizers for the invitation. I think this is an exciting program, and curious to see what some of the options are in what is effectively a really terrible disease, as everybody understands. I'm going to speak about Trans-Arterial Micro-Perfusion, or TAMP, as a relatively new technique for targeting pancreatic adenocarcinoma. And I think it's worthwhile to mention sort of what the problem is. You know, it's a serious disease, third leading cause of cancer death in the U.S. currently. And even with surgical disease that can be resected, there's a 20% 5-year survival. So even in the best case scenario, this is a pretty dismal prognosis. Now, the challenge is with locally advanced disease that is not resectable, really the options to date have been the same as with widely metastatic disease, and understandably, the outcomes have been similar. And so there's a rational attempt at trying to address locally advanced disease with potential local regional therapies. And I think that's what this sort of meeting is all about, and whether we can influence prognosis in that way. So we'll talk briefly about a case, 84-year-old male with locally advanced unresectable pancreatic adenocarcinoma of the pancreatic head. This is the typical way that these cancers present, these hypovascular tumors. They're very infiltrative. They tend to wrap around the vessels and permeate the stroma of the tissues in the area. And that's why resection is often not a good option, or not even technically feasible in this case. And you can see this reformatted MIP with the blue-purple tumor, kind of how it abuts and encases the mesenteric vasculature. That's part of the challenge of this tumor. So one thought is, can we take some of that natural tendency of this tumor to wrap around blood vessels and leverage that to treat it? And that's really what TAMP is about. This was from a company, Renova RX, that created this double balloon occlusion catheter specifically designed for treatment of pancreatic cancer in this way. The idea being presented in this schema here, that you isolate a segment of artery that has cancers around it, and you actually permeate the interstitium of the tumor with drug of choice, and in this case, chemotherapy. And so this is much more akin, I think of it much more akin to like a direct tumor injection rather than a procedure like chemoembolization, where you're actually trying to target blood supply feeding the tumor, such as a conventional chemoembolization in the liver. This is very much different than that. In fact, you don't want any blood vessels in the area, because that just sumps away your treatment. And we'll discuss that in just a little bit. But the idea is you're actually delivering the dose directly into the stroma of the cancer itself by isolating the segment of vessel that is abutting the cancer. How does this work? Well, there's a pressure increase that happens with the infusion, and you can see in this pressure tracing, when both balloons are up, the pressure obviously declines significantly. However, when you start the infusion here in this area, you can see the pressure in the vasculature starts to rise. And at some point, as demonstrated in this cartoon, the material actually leaks out, permeates the blood vessel wall, and leaks out into the interstitium, leaving very little of the chemotherapy left in the vessel, and most of it actually out in the interstitium. So this is the device itself. It's a double balloon occlusion catheter. It goes over an 014 wire, and you thread it through the relevant vasculature that has the tumor surrounding it. You isolate that segment, and most of the procedural time is actually spent finding that isolated segment and not exposing other little side branches that could sump away your chemo. Once it's in position, then you give the treatment, and the treatment is delivered at 6 mils per minute over about 20 minutes. Now, the dose, especially for pancreatic cancer, is essentially 1 gram per centimeter per meter squared. So it's a body surface area or weight-based dosing. It's very similar, if not identical, to the dose that's delivered intravenously. The only difference is you're trying to maximize the dose to the tumor and minimize the dose to the rest of the body. There are some nuances to understand with this tumor early on. There were some infections, particularly with patients who had had biliary instrumentation. And so now there's a protocol to treat patients who had had prior biliary instrumentation or a biliary stent, which is not uncommon in this population, as you can imagine, with a combination of metronidazole and ciprofloxacin or moxifloxacin, both peri-procedurally as well as for a week afterward, to prevent infectious side effects. These are procedures that are done with moderate sedation, generally same-day procedures. There's not a lot of post-embo kind of symptomatology with this. Occasionally, the patients may get a mild abdominal ache during the infusion, and it's unclear whether that's from the occlusion catheters being up or from the actual infusion into the tissues. And then once that's out, the system comes out and a closure device is employed and the patient goes home that same day. Now, there is a protocol, and this protocol is really on trial at present. So the Tiger Pack trial is a phase 3 multi-center international trial looking at the benefits of delivering gemcitabine through this transarterial microperfusion route compared to gemcitabine delivered intravenously. And this is the schematic of the current trial. Unresectable, locally advanced, treatment naive with no metastatic disease and normal hepatorenal function. Those are sort of the baseline characteristics. There is an induction phase that includes a couple of cycles of chemotherapy, followed by local radiation therapy to the cancer. And I'll mention this in a second because it's not necessarily standard of care, but it's enough of a standard of care that it's essentially reimbursed as standard of care, followed by an additional cycle and then restaging to ensure no metastatic disease. If there's no metastatic disease at that time, then they get randomized to either intraarterial therapy or ongoing IV therapy. And the intraarterial therapy arm, it's a total of 8 treatments given every other week over 16 weeks. So that's the real difference between the two arms, is that for 4 months, the on-treatment patients get intraarterial therapy for 4 months, and the control arm gets intravenous therapy according to the same cycle. And then everybody goes back to continuation therapy with restaging. And why the radiation therapy? Well, early on in the experience during the early phase analyses of studying this type of delivery, the study team noticed that those who happened to have undergone radiation therapy to the tumor bed actually enjoyed better survival. And even their survival after treatment with the intraarterial component was improved. So it wasn't just the overall survival. In other words, not additive because they just had better survival with radiation plus arterial. There was somehow, a thought that maybe the radiation therapy was synergizing the transarterial component of the treatment. And I think part of the understanding of that is right now still hypothetical, but the thought is that maybe some of the perivasculature around the tumor gets obliterated with the radiation therapy and allows longer dwell time of the chemo. So this is a translational study. This is an animal study where the balloon occlusion catheter was delivered in a mesenteric artery and methylene blue was administered. And you can see the methylene blue staining of the tissues. And you can see these thin, wispy, vascular looking things along the periphery. That's probably related to the vasculature in the interstitium. So by cartoon, if this is what it looks like, these small little black particles are the particles of chemo that are in the interstitium that have leaked out of this vessel. The idea is that with radiation therapy, maybe you obliterate some of these perivascular blood vessels and enable more of that chemo to dwell without getting sort of siphoned away. So the current protocol revolves around some prior radiation therapy as a result of that. So what kind of outcomes are we seeing with this? Well, there have been a couple of interim analyses that have been done to date, and they basically are essentially recapitulating some of the earlier analyses that led to the phase 3 study. So these are not the interim analyses, but these are some data from the earlier phases of the trial where you can see the on-treatment patients enjoyed a slightly better survival, up to 65% in a little over a year for those who got the most amount of cycles of intraarterial therapy, compared to 37% for those getting just systemic gemcitabine. And notably, adverse events and particularly myelosuppression was significantly lower in the intraarterial arm. So also sort of corroborating this idea that systemic exposure is decreased in this setting. And the current interim analyses essentially have mirrored this, about a 60% improvement in survival and 60%, 65% improvement in adverse events. But we'll really have to see for the final analysis to see how this bears out. So here's an example case. You can see this is a patient that has a celiaco-mesenteric trunk. You can see the biliary stent in position. There's some vascular irregularities where the red arrows are. Those are areas of tumor encasement with the blood vessels. You can't necessarily rely on that during the angiogram, so we usually use a combination of the CT and landmarks to know exactly where to deploy the balloon occlusion catheters. And on the right, you can see the balloon occlusion catheter is deployed. These are very soft, compliant balloons, so they tend to mold to the shape of the blood vessels. So they often look quite amorphous like that, rather than an angioplasty balloon that has a very defined shape. These are very compliant balloons. And really the trick, as I mentioned earlier, is to isolate a segment of the blood supply in order to facilitate perfusion into the interstitium. And once you've done that, you sort of deliver the dose over the course of 20 minutes. How does TAMP work? So we mentioned the one kind of component where it was sort of a pressure mediated delivery leaking out of the vasculature, and that very much seems to be true. And we've corroborated this through a translational study looking at what happens with the pressure, mean pressure, when you don't have any side branches compared to when there is a side branch. And I'll tell you, that can be a real challenge clinically because there's a lot of little branches that feed our mesentery. So these are the two kind of components here. Here you can see the contrast is staying isolated, no side branches, and you can see the pressure in the segment nicely increases, and then when the infusion stops, it decreases. Whereas in this circumstance here, you can see this small little side branch at the bottom there. Even that tiny little side branch actually prevents that pressure rise from occurring. And that can be a real limiter in terms of actually delivering the chemo into the interstitium. So again, this is an interstitial-based delivery. It's not a transarterial tumor-feeding blood vessel type delivery. And then again, this is now in lung, just as proof of concept in a swine model. This is, you can see methylene blue injection with focal staining of the parenchyma with dense methylene blue, very little staining peripherally. And when we deliver gemcitabine in this way, you can see the graph in purple and blue there. Clearly with TAMP, you get almost 2 orders of magnitude higher local delivery of gemcitabine compared to with systemic delivery. And then in terms of the actual mechanism of how it gets into the interstitium, we did this gold nanoparticle permutation study where we actually saw the nanoparticles in the vasa vasorum of the vasculature. So that seems to be at least the working hypothesis currently, that the material is going through the wall of the artery, through the vasa vasorum, and into the interstitium. And that seems to be kind of the way that the permeability is occurring. So we'll go back to another case, a 78-year-old female, locally advanced unresectable adenocarcinoma at the Uncinate process now. Here you can see that stroma, that dense hypovascular cancer that's kind of invaded around the tumor. You can see on the coronal reformat the sort of irregularity of the vessel involvement. Here you can see the very clearly abnormal blood vessels that are involved with the cancer there. And here's our balloon occlusion catheters in position, isolating that segment. And here we're delivering the chemo, and you can see the contrast is staying in that isolated segment and not leaking away. And those are the balloon occlusion catheters. And again, you can see how compliant they are, and they take whatever shape they need to isolate that segment. And then afterward, again, you can see that very irregular blood vessel. This was kind of something to be mindful of. If you see an irregularity like this, there's a high likelihood that delivery and just from the treatment itself, that branch may occlude with time. And so we do have to be kind of mindful of the local toxicity, even though there was relatively minor local toxicity of the vasculature seen in a translational study, certainly the possibility of a mesenteric thrombosis needs to be sort of in the back of everyone's mind, and we do heparinize these patients during the delivery because of that. And diffuse mesenteric venous thrombosis is therefore a contraindication for this type of treatment. And you can see here 1 week later, those small little branches actually had thrombosed. However, in this circumstance, the patient remained asymptomatic. And when you see what happens to the CA19-9, this precipitous decline, it's always very encouraging to see that as a response to the treatment. So again, we'll have to wait for the final results of the phase 3 to be reported, but this could help define a new standard of care for.
Hi, everybody. I hope you can hear me. And Dr. Prasad, thank you for that fascinating presentation and clear explanation on how to increase the drug delivery to the tumors. The results are really, really encouraging. And this is a good segue into our next talk about focused ultrasound treating tumors. Now, focused ultrasound is also in clinical trials to enhance the local delivery of medicines to pancreatic tumors, but without the use of catheters. We'll hear about that in a little bit. But for now, Dr. Vidal-Jove will discuss how he delivers focused ultrasound right through the intact skin to kill tumors with either heat or mechanical ablation called histotripsy. So I'd like to introduce him. Dr. Vidal-Jove is a physician scientist specializing in cancer surgery trained at the University of Barcelona. He's the principal investigator of the first clinical trial of histotripsy in human liver tumors. And as a scientific surgeon, he has focused clinical research on the specific impact of ablation on advanced pancreatic and liver tumors, both locally and systemically through the action of immunity, which we'll discuss in the Q&A. So Dr. Vidal-Jove, the floor is yours.
Well, thank you to the organizers for inviting me to present my experience in pancreas cancer treated with focused ultrasound, thermal therapies, and histotripsy. So this is the purpose of this presentation, and I hope that it's going to be interesting for all of you. Well, first of all, the disclosure that we have to put related to the histotripsy. And pancreas cancer, as everybody knows, has a very terrible prognosis, and the survival is very low. It accounts for 77% of all cancer deaths, and in the United States, approximately almost 70,000 new cases are expected in this year. The prognosis, the 5-year survival is around 13%, and the only case where we can have good results, at least, is the 20% of the cases that are resectable, because they are diagnosed when surgeons can do their job. But the remaining 80%, which is 30% that are going to have locally advanced pancreatic cancer or non-resectable pancreatic cancer, and the rest are going to have metastatic tumors. The prognosis that I was saying before is the 2 years overall survival is lower than 20% with classical chemo or classical radiation, but with ablative radiotherapy and the new radiation therapies that are being employed recently, this prognosis has been increased, but still is very low as we desire. Well, in non-invasive therapies for pancreatic cancer, for non-resectable pancreatic cancer, for the ones that we can treat, we are going to face different challenges. We're going to face the possibility to have pancreatitis, thrombosis, bleeding, injuries of the structures that are around the pancreas, the bowel, the ducts, the management of the stents, because most of these patients are going to have biliary stents because of the jaundice, and these biliary stents may interfere. And then the difficulties differentiating the tumor from the normal pancreatic tissue. And this is something that's going to be our most important challenge. So talking about thermal therapies, I can explain our experience in the last 12 years, from 2009 in Barcelona, when we were treating more than 200 malignant cases, and specifically we treated more than 80 pancreatic cases, stage 3 and stage 4 pancreatic tumors. And we were doing this with this very nice device, this device from the Chongqing Haifu company, the JC and the JC200, that, as you can see in the pictures, is a device that is fixed. And then we have to place the patient above this transducer and the water bath, and we have to move and place the patient to obtain the targeting and the treatments. In the next slide, we see what we collected as experience in this hospital. With in the first cases, in the first 40 cases, we did a comparative study between patients that we were doing HIFU plus chemotherapy and patients that were doing only chemotherapy. So we collected 2 different cohorts that were matched, and they were equivalent for age, sex, and diagnosis stage, and we compared these both cohorts to the treatments. And the comparison was clearly favorable for the patients that did HIFU plus chemotherapy. And the survival analysis of these 2 cohorts showed a statistically significant benefit for the patients with HIFU, and the probability of dying was clearly lower in these patients. Recently, last year was published this analysis of all the experience obtained, not just in the Western world, but in China and in Asia, where they have the most experience. In this paper, they collected 450 publications, different type of publications, and they made the analysis of the databases obtained in the Western world and the databases obtained in China and Asia. And well, the conclusions were very clear in favor of this technology. The toxicities were very mild or very low. The discomfort, pain, skin changes, mild fever or mild inflammatory reaction were very low, very mild. The infection or necrosis, the increase of pancreatic enzyme was also minimal, less than 2%, and other problems were also very, very low. The conclusions of the study is that ultrasound-guided HIFU is safe and effective. Is a non-invasive treatment for these patients. The patient's quality of life is significantly improved in the majority of the patients, and HIFU can be performed also additionally to other technologies. It's something that mixes very well, complements very well radiation therapy or chemotherapy. So it's very well done with all these technologies, and it encompasses very well this treatment in the palliative setting of this condition. Recently, it has appeared a new technology, histotripsy. And histotripsy, it's a new type of technology. It's a non-invasive, non-thermal, robotic cavitational tissue destruction that is done completely different as the one that we saw before. Here, the device is placed above the patient. It's controlled by a robotic arm, and the treatment is done without moving the patient. So it's a robotic arm that is placed above the patient and treats and obtains the tumor destruction. The differences between the 2 conditions, the thermal therapy and the mechanical, you see it here in this graphic. We see that the wave is different in both. So in the thermal is a low amplitude and low intermediate pressure treatment that obtains the thermal ablation, and with the mechanical histotripsy is high amplitude and high pressure wave that are seen and as you see in the graphic in the slide. Here in this slide, you can see how it's produced what we call the bubble cloud, what will destroy the tissue with histotripsy. So you raise the voltage, and raising the voltage, the bubble cloud appears based on the structure and of the tissue. So the characteristics of the tissue makes you that your voltage has to be higher to or lower to obtain this bubble cloud. So that means that this is very well personalized for the characteristics of the tissue that you're going to destroy. We're going to talk now about the study that we're doing at present, the first in-human study for histotripsy on pancreatic tumors. In the pancreas program of histotripsy is done after being done. The preclinical study is now in the clinical phase, and in the coming months we expect to have real-world findings of patients that have been treated out of the clinical trials. Well, in this slide, we see here how histotripsy can help in the different possibilities of this disease, either in resectable tumors, in borderline resectable, in unresectable tumors, or in metastatic tumors. And you can see it here how we can manage this treatment in the different possibilities with the pancreas disease. Well, let's talk about the specific trial that we're doing now. It's called the Ganon trial. The design of this trial is a safety trial. This is something that is very important to understand, that because it is a safety trial, we were not able to treat complete tumors. We were organized to do partial ablations, and we decided that the best way was this, to do 3 cohorts. In the first cohort, we were going to treat only 1.5 centimeters treatments. In cohort number 2, we were going to do until 2.5 centimeters diameter treatments, and those we were not going to cover the whole tumor, so we were going to only be doing partial treatments in tumors. And in the third cohort, that is not yet started, and it's going to be started in the coming weeks, we will be treating until 4 centimeters. And with this, we will be able to cover the full tumor. So the results that I'm going to show you now are partial treatments in pancreatic tumors. We have included locally advanced tumors and oligometastatic patients with less than 5 liver or lung metastases. So in the trial, we have completed cohort number 1 with 5 patients, and we are in the middle of cohort number 3 with with 5 patients with no real problems seen in these patients. So the lessons that we have learned, and then I will show you cases in the next slides to show you that, is that we can target and see clearly the bubble cloud into the pancreas. The gas interference between the abdomen and the tumor has not been a problem with the management that we have been doing with a protocol that we use to minimize gas with a special diet for the patients and a solution that we do like the patients who are going to have a colonoscopy. So it's the same type of management. The bowel control is very well obtained. We can manage the vessels with no problems. We also have seen and treat nearby biliary stents, and we can clearly differentiate with ultrasound the tumor from the healthy tissue and minimize the risk of pancreatitis. We see here the first case that we did. In this case, we did a fusion between the CT scan and the ultrasound, and we see here clearly the tumor that is above the celiac trunk with a fusion here, and the treatment that we have done above the celiac trunk. We see it here in this image. In the next slide, you will see how how this has been performed. And we see here what we see in the image of the Edison device. And now we will approach the image, and we'll see how we can clearly see the bubble cloud when we are treating the tumor above the celiac trunk. So we see here the celiac trunk and the bubble cloud that is very clearly seen in this image. We see here that the result 36 hours after the treatment of the partial treatment that we did in the tumor. And 1 week after, also the same image on the CT scan. Same 30 days post, 60 days, and 120 days, the image of the treatment on the CT scans of control. That's the patient number 2 that we did. We treat a tumor nearby biliary stent, and we can see it here, how we see it, and we see clearly also the bubble cloud nearby the stent, and the stent was not interfering in our line of treatment. And this is the image post when we see clear the treatment done. And this is another case where we were treating here the tumor. Here clear we see the normal tissue, the tumor, and a cyst. And here we were including the splenic artery into the treatment with no problems. We see here the image before and after, and we see it here and in the slide. So this is the last image, last case that I'm going to show you is a tumor treated on the tail of the pancreas. This is a cyst nearby the tumor, and this is what we saw when we were treating the case. So we were managing the tumor and seeing nearby the bowel, small bowel, colon, and the treatment being done. And that's the images after the treatment, the cyst and the treatment done, and the image of the CT scan after. So next steps of this trial are ready to go. We have completed 10 patients now. We are about to start the cohort number 3 with more patients, and now we are going to aim to treat the full tumor. We have had no toxicities, only 1 patient that had a cholangitis, an infection of the stent that was treated with antibiotics and replacing the stent. And this is the group. I'm very thankful to Histosonics and to people of surgeons and interventional radiologists of the Hospital Sant Pau in Barcelona, and is really a team effort. And this is what I always say to my group. So ready to take questions, and thank you for your attention.
Thank you, Dr. Vidal-Jove. That was very fascinating. I think we'll save questions for the end, but for now I want to introduce Dr. Narayanan from Baptist Health, South Florida, where he is the many roles, but most recently the Medical Director of Interventional Radiology, as well as the founding chairman of the Department of Interventional Radiology at the University of Miami Miller School of Medicine. He's going to talk to us today about irreversible electroporation in pulsed electric fields and its use for the pancreas. So thank you.
Hello, everyone. My name is Raj Narayanan. I'm an interventional oncologist at the Miami Cardiac and Vascular Institute. I would first like to thank the Focused Ultrasound Foundation and SIO for the opportunity to talk to all of you about the new frontiers in ablation in pancreatic cancer. Pancreatic cancer, as we all know, is one of the most lethal malignancies out there, and it's also a silent killer. Most of the patients, when they're diagnosed, nearly about 50% of them have distant metastases and fall under stage 4 category. And about 30% of these patients, even though the pancreatic cancer is not metastasized out of the pancreas, are considered to be locally advanced, meaning that the vessels around the pancreas are encased with tumor, which makes it not possible for the surgeon to get a R0 margin or a clean resection. So there's only about 8 to 10% of these patients who fall under stage 1, where they can undergo a Whipple procedure. So the treatment options mostly falls under the purview of medical oncology with or without a combination of radiation. And until about a decade ago, interventional radiology was mostly involved with palliative measures in treating these patients, mainly to provide drainage of the biliary system or for pain management. So this has changed with the introduction of local ablative treatments for pancreatic cancer. And radiofrequency ablation, microwave, and cryoablation have all been tried as local ablative treatment options, and mostly in the operating room, but they have not found mainstream acceptance due to the increased mortality and morbidity. Irreversible electroporation, or IRE, in pancreatic cancer is the newest technology, which is about a little over a decade old, that has been introduced in the treatment of pancreatic cancer. And the use of IRE in pancreatic cancer is considered to be off-label. So the rest of the talk, we're going to look at the technique of percutaneous pancreatic IRE, patient selection, some case examples, data, and future directions. So let's start with what is electroporation. Electroporation is a technique that increases the permeability of cell membranes when they're exposed to high voltage, low energy DC current, and they create pores in the cell membranes, which can be reversible or irreversible. When the technology was initially introduced, it was reversible electroporation, and the scientists at UC Berkeley figured out that if they increase the voltage from 1,000 volts to 3,000 volts, the pores that were created in the cell membrane were permanent, and there was cell death independent of chemotherapy, and that led to the introduction of irreversible electroporation. So this animation of ablation with irreversible electroporation is a little different from what you would typically do with thermal ablation. Here you have a touchscreen interface where you can adjust the voltage. The maximum voltage you can deliver between two probes is about 3,000 volts. You need a positive and a negative. And at any given time, energy is only delivered between two probes. Therefore, you can use odd or even number of probes. So in this particular instance, we're going to be placing 4 needles, labeled 1, 2, 3, and 4. And once they are in position and the appropriate distance has been confirmed, we turn on the machine, and energy is first delivered between probe 1 and 4 here, and then it automatically switches to 2 and 3. 2 and 4, 3 and 1, 3 and 4, and 1 and 2. And that's how we accomplish a complex ablation zone. So you can add or subtract pairs depending on the coverage that you require. And currently, the number of pulses that we deliver between two probes is 70. This animation shows 90, which is still used for the prostate, but for the rest of the organs, we've dropped it down to 70 pulses. This is a generation 3 device. It's commercially called the nano knife, although there's no knife involved. And the good part of the 3rd generation is that we can watch the electroporation graph being populated as the treatment is being delivered. So what we are looking in this graph for, what we would like to see, is an upward slope as the energy is being delivered. And this tells us that the cells are electroporated and more electricity is passing through. So we would like to see a delta of about 15 amps between the start and the end of the treatment. So it goes in packets of 10 pulses. And for a complete treatment between 2 needles, we need at least 70 pulses. For pancreatic IRE, we start with the patient in the CAT scan room. The procedure has to be performed under general anesthesia. We need these patients to have a nasogastric tube. And the role of the nasogastric tube is twofold. It helps us inject oral contrast so we can visualize the stomach and the small bowel, and that gives us a much better understanding of the anatomy around the pancreas. And B, after the ablation is done, we connect the nasogastric tube to intermittent suction. This allows us to keep the stomach and the GI system decompressed so that there's no mass effect from the ablation, which can potentially lead to outlet obstruction in these patients. The probes are placed with CAT scan guidance, and typically for the pancreatic IRE, we expose the active tip to about 1.5 centimeters, And once we place these needles in, we support them with some towels so that the probes can maintain their angle and the depth. And we get the check scans before we make adjustments to the needle placement. Even the procedure has to be done under complete general anesthesia with muscle relaxation. And even with that, you're going to see some movement of the probes, and that's normal, and that's something to be expected. With the IRE, you cannot perform track ablation the way you would do with thermal ablation, such as microwave. And therefore, what we typically do after the treatment is completed is that we close the active tip of the needle and remove the probe after that. And this has helped us avoid the problem of track seeding. So the mechanism of healing for IRE is also different compared to thermal ablation, where you have coagulative necrosis, fibrosis, and scarring. With IRE, it's postulated to be apoptosis. So as you can see in this example in the liver, the area that was treated 24 hours post-IRE, you can see a large ablation zone, but the same area completely decreases in size in 5 weeks, and by 5 months, you can barely see the ablation zone. What are some of the complications? In this particular case, there's a needle that's being placed, and we probably touched a vertex on the way, and you can see the hematoma. So bleeding is a complication that needs to be kept in mind, and we need a clear path for the needle to go from the skin to the target. Pancreatitis is another complication which we describe to patients and discuss before the treatment. Typically, we do not see the problem of pancreatitis in patients who've had previous radiation, but if somebody is getting a de novo IRE after induction chemotherapy, then there is definitely a risk of pancreatitis. Usually, these patients are kept NPO after the ablation, and then we check the amylase and lipase the day after in the morning. And if they're normal, we remove the nasogastric tube and then start the patient on clears and then advance the diet during the day and then discharge them the day after the ablation. If they have elevation of the amylase and lipase, we maintain them with just ice chips and then repeat the amylase and lipase the next day. Usually within 48 hours, it should go back to normal, even if it's elevated. So who's an ideal patient for IRE of the pancreas? This would be somebody with a stage 3 diagnosis with a performance status of ECOG 0 to 1, someone where there's a safe access to the tumor, and a patient who's completed at least 1 line of chemotherapy. After the ablation, we follow up these patients in our clinic at about 1 month, and we ask them to obtain an MRI of the abdomen with contrast and diffusion weighted sequences, and we repeat that at 3, 6, 9, and 12 months. We also obtain a PET scan at 3 months post-ablation if they had a pre-ablation PET, and all of the imaging is done in addition to the labs and tumor markers, specifically CA19-9. So this is an example of open versus a percutaneous technique. Obviously, the IRE of the pancreas is being performed more in the open setting by surgeons, which carries a slightly higher morbidity and an increased length of stay in the hospital compared to the percutaneous technique. The pros and cons for percutaneous IRE, the pros would be this is minimally invasive. You can have precise placement because you're using CAT scan guidance. The results from the percutaneous series have all been shown to be comparable or even slightly better than the open technique. You can perform post-ablation imaging immediately with the CT, so you can check for any potential injury to the vasculature or any adjacent structures, less morbidity and a shorter hospital stay. The cons is that it's not for all patients. You need a safe access when you're doing it in the open setting. You're able to move the adjacent structures and place the needles directly onto the pancreatic tumor, which you cannot do when you're doing this percutaneously. Of course, bleeding complication is a possibility. And like we described earlier, you cannot move structures when you're doing this percutaneously. Let's look up some case examples. This is a patient who had a encasement of a replaced right hepatic artery and locally advanced pancreatic cancer, about 1.5 centimeters in the uncinate process. Biliary stent is in place, and you can see the vasculature, artery, and veins in close proximity. So this was our planning scan where we found a path to advance the needle. And this is a short video of the needles being placed, and we were able to go anterior to posterior. And after the needles are placed, we perform a 3D reconstruction to make sure that the spacing of the needles is appropriate. We want them to be under 2.2 centimeters. And after that, the treatment was completed. And this is the immediate post-IRE contrast-enhanced CT, where you see the vasculature is maintained, and that's the hypodense area where the treatment was done. Same patient at 1 year post, no evidence of local recurrence. 18-month follow-up, no evidence of local recurrence. And here's another example, a 64-year-old patient with locally advanced pancreatic cancer involving the head of the pancreas. Here is our lidocaine needles to assess the path. I'm showing you the pre-PET scan of this patient where you can see a large PET positive area. So here we're seeing the probe placement to bracket the tumor involving the head of the pancreas. And after that was done, we repeated the CT with contrast, and you can see all the vasculature is maintained, no evidence of vascular injury. And here's the ablation zone with some air in the treatment zone, which is to be expected, that is secondary to hydrolysis. So CT scans typically don't do justice to the treatment effect. And here you can see the post-ablation PET scan where the area is now cold on PET. And here's a comparison of the pre and post PET scan in the patient after the IRE. So let's look at some data for percutaneous IRE. We published the first human series with 14 patients, and then followed up with another series of 50 patients. Professor Meiring from the Netherlands also published in a group of 50 patients, and then Dr. Lean from the UK, 75 patients, and Sugimoto from Japan with 8 patients. All of these cases, all of these studies show an improvement in median overall survival from diagnosis compared to conventional techniques or the conventional standard of care, ranging from 17 to 27 months. This is the prospective study, single-arm phase 2 study, again from Dr. Meiring's group in the Netherlands, called PanFire-2. This study was to investigate the safety and efficacy of percutaneous IRE in locally advanced pancreatic cancer and for locally recurring pancreatic cancer. And the primary endpoint was the median overall survival from diagnosis. The target median overall survival was 11.6 months for patients receiving no induction chemotherapy or gemcitabine-based induction chemotherapy, and 14.9 months for those receiving induction chemotherapy with FOLFIRINOX. The study was positive. It met both endpoints. The groups met their endpoints. The locally advanced pancreatic cancers was 17 months, and the median overall survival for those with local recurrence was 16 months. This study is a meta-analysis of all the data that has been published in pancreatic cancer using IRE, and this includes both surgical and percutaneous IRE studies. And if you look at the median overall survival, you can see that a vast majority of these patients have a median overall survival which is better than the current standard of care. Switching gears to the DIRECT study, which is now closed. This was an FDA-approved trial that included 2 arms. One was patients who were randomized to chemotherapy versus chemotherapy and IRE, but it also had a registry along with a control arm. The RCT failed to recruit patients. We only had 1 patient, but the registry had a healthy recruitment, well over 200 patients. And currently, the early results of the DIRECT study are undergoing peer review, and you should see them pretty soon. So how does ablation fit in the world of locally advanced pancreatic cancer? Typically, these patients after diagnosis undergo induction chemotherapy and are restaged with their CT and their CA19-9 response. If they're potentially candidates for surgery, there's an exploratory laparotomy, and they undergo resection and adjuvant chemotherapy. If they have non-progressive disease and locally advanced pancreatic cancer and not able to go to the OR, then they get local ablation and then continuation of chemotherapy. And if they have progressive disease, they go on to more clinical trials. So what are some of the future directions for IRE? We have incorporated robotic assistance into our practice, which is now pretty standard for all the ablations that we do. We've also performed the first robotic ablation of the pancreas with imaging guidance. And this has changed how we perform ablations in our workflow. The robotic guidance not only helps you with the precision, but it also helps you to plan trajectories for multiple needles with a single click. It allows you to overlay the tumor with the ablation volume. It allows for MRI fusion, and all of these characteristics help improve the workflow. And currently, our data is also the first 100 patient data is under peer review. Some of the other areas where there's work going on is to looking at the role of IRE along with immunotherapy, where it has been shown to elevate immune suppression and creating a window for anti-T cell activation. And these are also studies from the Netherlands. This is an animal study from MD Anderson group that in the murine model looked at the role of IRE and it was shown to reverse the resistance to immune checkpoint blockade in pancreatic cancer. This particular study looked at T cell activation and immune memory enhancement that was induced by IRE in pancreatic cancer. They found that IRE suppresses tumor growth and increases CD8 and T cells. This was through enhancing specific immune memory. IRE led to complete tumor regression, induced abscopal effect, and suppressed growth of latent lesions. So they summarized that prospective and retrospective studies so far have shown that IRE shows a benefit in improving survival in patients with locally advanced pancreatic cancer. This technology has been around for more than a decade now, both in the open and in the percutaneous setting. And ablation in pancreatic cancer is a viable local treatment option when it's used along with current treatment standards.
Oh, wow. So thank you so much for that talk. And, I think this all gives everybody tremendous hope for the future of treating pancreatic cancer. But Dr. Berman, I'd love to hear your thoughts and start us on the Q&A.
Yeah, this is fascinating. And I love that there's many different approaches from different angles trying to target how we can treat these. Which again, like I said before, is very encouraging given kind of where we were at maybe 20-something years ago. I'll ask a somewhat provocative question. I think most people these days are looking towards the immune activation, and particularly IRE and histotripsy are two modalities that people have looked at particularly. And to one of the other questions that we had in the Q&A about partial ablation versus not, I guess my question for the panel is, where do we see the future of this, and how do we prove that we're making 1 + 1 = 3, making the immune system active against cancer?
Thank you for the question, Zach. I think I can answer the part for IRE. There have been animal studies that have been published in JVIR. One that compared Sarah White's study comparing cryo with IRE, showing immune response with both, but better with IRE. The answer specific to pancreatic cancer will be, we're all expecting the results of the PanFire-3 trial, which is, again, conducted in the Netherlands, and which should give us, it's a true randomized trial, and should give us the answer about adding immunotherapy with IRE if it has a benefit in treating pancreatic cancer or not. So hopefully soon.
From my side, talking about histotripsy, I mean, histotripsy has a proven track record of abscopal effects. We've done it in our trials, in our Teresa trial, in our first in human trial with liver lesions, when we had 20-something% abscopal effects. We had 2 abscopal effects out of 8 patients. And in our experience with commercial treatments, our experience is that between 20 and in some cases, in some reports, 30% of abscopal effects in liver treatments. In pancreas now, I can say that I cannot. The trial is ongoing, and I cannot count for the whole trial. But till now, and we have treated 10 patients, we have 2 abscopal effects that are, clear abscopal effects of 2 patients that had liver metastases that were cleared after local treatment, a local partial treatment in the pancreas. And responding to the partial treatments, where in our trial, what we have to do was kind of dose escalation. So because it was the first time that we were doing histotripsy in a pancreas, so we were forced to do small lesions first, and then bigger lesions, and then cover the full tumor. This is what we're going to do in the coming cohort. So that was the reason to do a partial treatment and to do it is like a dose escalation. But there is a couple of situations that we have considered that partial treatments in pancreas make sense from the clinical point of view. One is for palliative pain treatment. So if you want to pain control, probably a partial treatment is enough. And also, if your objective is to clear the vessels to obtain a resectable patient. So if you want to clear the vessels from the tumor, doing a histotripsy treatment in the vessels, clear tumor from there, and then go and resect the patient, that's where a partial treatment makes sense for the clinical point of view. And this is not something that we say, but we have, several physicians that are now in advisory boards, or people that are doing cases with histotripsy in liver, that consider that this is the 2 possible cases where partial treatments will make sense.
How about the post-histotripsy care for pancreatic cancer patients? Are these patients admitted, or are they going home the same day like other histo patients?
What we do is the same that the other histo patients, but we make the patients stay one night, and the next day we do the CT scan. We do it just for convenience of the patients. We do the case, then we make the patients get to admitted one day, and the next day we do the CT scan, and then they go home. So we haven't had any problem like in the liver histotripsy on these patients.
Any concern for pancreatitis? Do you check amylase lipase, or
yes,
is that part of this trial?
Yes, this is something that we check in all patients. We had a little raise of the amylase and lipase in one case, in one patient. It was one of the patients that we were treating near the stent, and in this patient we treat the tumor and a little more of the healthy tissue. And in this patient there was a little increase of the amylase and a little pain that was solved in 24 hours, only that. And but I see that when we are going to cover the full tumor, we will need to treat with margin. And with this margin, I don't think that we should have bigger margins like we do in the liver, but small margins, we will need to do those. And we'll see what happens there.
Dr. Vidal-Jove, what about thromboses? I know in the liver, portal vein thrombosis has been an issue. Do you heparinize these patients, and are you concerned about mesenteric venous thrombosis?
No, we do not heparinize these patients, and we in our cases, in the small experience with 10 patients, we haven't had any thrombosis. But this is something that we will need to explore more with more cases and more data.
Any pain for these patients post histo?
Not at all. Not a single pain. Well, only this patient that I just mentioned, the patient where we treated a little more of the healthy tissue, that had a little pain the day after the procedure, that was solved with normal painkillers and was solved in 24 hours. One of the patients that had pain in the pancreas, the pain was cleared after the procedure in 3 days. And for the procedure, no pain at all. So we use the anesthesia just to make the patients stay still and not move during the procedure, but not for any pain.
Changing gears a little bit, Dr. Farsad, I know right now we're talking about gemcitabine intraarterial delivery. Do you see the future other different types of drugs with maybe other mechanisms, and or in combination with other therapies?
Yeah, that's actually a great question. I'll tell you personally, my interest in engaging in this clinical trial with this technology was exactly that, is to leverage it for as a drug delivery tool, because essentially what it's trying to do is overcome, the drug delivery challenge for pancreatic cancer, and the high interstitial, pressures that exist and inability to get adequate drug. So for now, it's chemotherapy. But I think, that's one of the exciting potential avenues in the future. And to go with what you were stating earlier, seeing how we can potentially leverage directed therapy to stimulate an immune response. Because ultimately, for locally advanced disease, it's highly doubtful that any local regional therapy really could be definitive just because of the nature of this cancer. Unfortunately, it's very infiltrative, and so we will need to synergize it with some other sort of systemic therapy for a more durable response.
It's interesting with your platform of increasing drug delivery. There's some studies coming out of South Korea where they're using non-destructive histotripsy along with some medications to increase drug delivery there. And in one study that's about to be published, I believe in gastroenterology, the response rate was 64%. There was no control arm, but obviously better than the typical response. And there were no adverse events. And then in a follow-up study, 30 patients, 50 patients in a test group and 15 control studies, there was increasing survival. And the problem with those studies was that at the end of the study, the patients were still alive. So they had to extend the time period for follow-up because the patients were living longer, which is great, but we don't see the final results yet because they're living longer. So we're going to do larger studies with focused ultrasound in this kind of technique to also see whether that non-destructive histotripsy and improved drug delivery is going to have the effect that you're showing as well.
Could you explain to me what non-destructive histotripsy is? That's a new concept for me. So
Joan Vidal-Job, you want to take that or you want me to take it? You're muted.
Oh, yes, you take it.
Yeah, it's a form of breaking up the cells without necessarily killing all the tissue, but just opening the cell membranes, making it more amenable to the medication, and just not killing all the cells there. It also results in some improved immune response, because as we know, the histotripsy kind of releases tumor antigens and acts as like a neo-vaccine. So those results are going to be very interesting.
Well, the idea with the histotripsy is that, what we have experienced is that because you break the tumor and you preserve the vessels and all this structure, you expose the tumor antigens to the immune system of the patient. And that's probably the main reason that you may have there more abscopal effects, more immune effects, more off-target effects.
I know you both discussed HIFU and histotripsy, but what about LOFU? I know some people are looking at low intensity ultrasound as a way to do precisely kind of what Dr. LeBlanc was suggesting, sort of a non-destructive release of antigen.
Yeah, I think with the LIFO, we're exploring like you could do mild hyperthermia, release of drugs from encapsulated structures to have more local delivery. That's in its very early stages. I think there was a question in the chat for Dr. Farsad about occluding the vessel. Like, is there any danger of occluding that vessel while you're doing the infusion?
Yeah, so we heparinize during the procedure, and usually it's not an issue. If there is a very small vessel, the device is rated for 3 millimeters or greater, 3 millimeters up to 10 millimeters. So there is a risk if it's a very small vessel that it could get obliterated. Usually those are clinically silent. We have seen one case of mesenteric thrombosis secondary to the procedure that presented, several days afterward, but that's the only case I know about. But we do heparinize, and it's something to be mindful of. And that's also why venous thrombosis, diffuse venous thrombosis, is a contraindication for the treatment. But yeah, usually with full heparinization, it's only a 20-minute delivery. It's very tolerated. Yeah.
And Dr. Berman, like if patients are listening or their family members with patients interested in getting on any of these trials, like how do you figure out which patient is best for which trial and things like that?
Yeah, I highly encourage most patients to look into what clinical trials they may be a candidate for. And clinicaltrials.gov does have a patient-facing webpage where you can actually type in your cancer and your region, and it can tell you what clinical trials you have around. And then if you see a clinical trial that you may or may not be interested in, they always have a contact information there as well, where you can actually reach out to the principal investigator or their staff and see if you would be a candidate for it. Because, you can lose yourself in trying to read all the inclusion, exclusion criteria, et cetera. But, a quick 2 or 3 minute phone call with maybe a clinical trial coordinator can kind of help you guide to find a place. So I recommend all patients start with clinicaltrials.gov, at least in the US. That's the only system I know.
No, thanks. And for the panelists, maybe you could address this one last question. When patients come to you and they're thinking about a clinical trial, like how do you explain to them the opportunities and also challenges of being in a clinical trial? Like, what are those conversations like?
Well, in my case, in our case with lithotripsy, there is a lot of excitement in the patients that want to be treated. And in our problem is because it's the first trial and it's a safety trial. We have some requirements that we cannot avoid. And one, for instance, is that we can only treat patients that have no more than 5 liver or lung metastases. And this is a problem. We cannot treat also patients that have had previous radiation therapy because we don't want to mix lithotripsy with radiation therapy in this trial. In the future, that won't be a problem. But now in this trial, we're constrained about that. What we explain is that we are going to do the best to cover most of the tumor. Now in the cohort that we're going to start now, we can cover until 4 centimeters treatment. So that's going to be a big difference. And we want to make the trial to the most pure and possible, and patients understand that very well. And then when we have a good explanation, we have a great PI here in Barcelona, Dr. Santi Sanchez Cabos. He's a great leader. He's a very very caring physician. He's a surgeon. He's very well known in the HPV surgeon world, and then he takes care. He does an interview of the patient because we're taking patients from all over the world. And he's doing interview with them, an online consultation, and at the end we decide if the patient is able to enter or not.
Thank you. Dr. Farsad, what about you when you get patients?
Yeah, I think that's a really important question. And I think we, as investigators, have an ethical obligation to really explain a clinical trial for what it is, because especially with a very dire prognosis like pancreatic cancer, you can imagine there's a lot of hope that people have and they want the best. And there's this thought that what you're providing is necessarily going to be better. And I think we just have to be very clear that the trial, if we knew the intervention arm was going to be better, then there wouldn't be a trial, right? So the reason why there's a trial is to understand that question and make sure that there's a real sort of solid informed consent process from an ethical perspective. I think it's really important.
Thank you for reminding everyone about the importance of transparency and honesty, when explaining to these patients. Dr. Narayan, any last thoughts from you about this? You're on mute.
Yeah. So my challenge with the direct study was that the trial actually started several years after the technology was available commercially. So, which was one of the reasons that the randomized control trial could not accrue patients. But I fully agree with all the other panelists. When we sit down to talk to patients about the studies, we definitely go through the pros and cons of why the study would be important. But again, since there was already data that was published, most patients wanted to have the local treatment and they opted for the registry. But it is important to go through the everything regarding the trial, including what could go wrong. I think that's very important.
Yeah, no, thanks for those words. Dr. Berman, any last thoughts from you?
No, this is fantastic. I sure learned a lot, and it's really exciting to see the future for sure.
No. Well, thank you, everybody, to the panelists. Dr. Berman, thank you so much. I think we all really learned a lot. There's much more collaboration and research to be done. If your questions were answered or if you'd like more information, you can visit our websites at fussfoundation.org or the SIO website, or email us at info@fussfoundation.org and info@scio-central.org. I'd like to thank everybody again, and also thank Kim Martini-Fear from SIO for her collaboration on the webinar. In addition, this webinar would only be possible with the expertise and professionalism of my staff. So thank you to Paige Rice, Joe Rice, and Jenna Brazzi. You will all actually receive a link to the recording of today's webinar from Zoom directly. So again, thank you for joining us. Check out our newsletters, contact us if you want any more information, and I hope you all have a fantastic day.
Thank you.
Thank you very
Thank
much.
you.